Welcome to Spine Conference. Today's discussion will be Unilateral Laminectomy Bilateral Decompression. It's a mouthful, right?
It is a mouthful.
So, this is a man at the grocery store across the street, and he's not walking straight. Why is that? I mean, you walk pretty straight. I walk reasonably straight. Why isn't he walking straight?
It's more comfortable for him.
Yeah,
to
why is it
forward?
Why is it more
Probably
comfortable?
because he has pressure on his nerves in his lumbar spine.
The spinal stenosis, and when we flex forward, the ligament inflavum in the interlaminar space stretches, and it gives the spinal canal more room. And then what happens? You can see his hips are flexed. These people get flexion contractures of the hips as well, and so they get stiff in this position as well. And just a quick question: is this comfortable, or this is an uncomfortable position for you if you did this?
For me, it's uncomfortable.
Super uncomfortable, yeah, because you see the balance. The head is way forward from the sacrum, so it's a very unbalanced position. So the best position is like a Marine standing at attention. Everything's lined up, and you can stand like that forever. So this is a very uncomfortable position for people, but they have to do it, usually because of spinal stenosis, and that's going to be the topic today. Spinal stenosis can present just with leaning forwards with walking, but also it can present as low back pain and pain down the lower extremities. You have to differentiate neurogenic claudication from vascular claudication, and sometimes it's impossible to know the difference, but usually you can. Vascular claudication, it can be real severe, like on the right. You can see ischemia or death of the toes. Usually, vascular claudication is severe pain with abulation, and usually they describe it as a cramping in the calves. And then when they stop, the cramping goes away, but then they resume walking, the cramping begins. But in neurogenic claudication, people usually say the pain starts when they walk, and when they bend forwards or they sit or they squat, the pain goes away. So it's a little bit different. Neurogenic claudication usually is not severe. It's usually chronic. Vascular claudication can be very severe when they ambulate. So neurogenic claudication is a compression of the nerves, and this is a cartoon of the lumbar spine, and the spinal cord ends at L1, L2 usually 85% of the time, and then below that is just nerve roots called equina. It looks like the horse of a tail, and the pressure here gives you pain. Pressure here in the nerves can give you pain in the back and the legs. The nerves travel down the tube, the spinal canal, and the spinal canal borders the floor of the spinal canal is the vertebral body. The outsides of the spinal canal are the pedicles, and then the roof sort of the spinal canal is the lamina. And this is a picture of Mixter and Barr. Do you know who Mixter was? He, in 1934, was the first description of doing surgery for herniated discs as a cause of sciatica at Mass General, 1934, a long time ago. So, lumbar stenosis was described in 1940 by Verbeest, where using myelograms, he noted that people with neurogenic claudication type symptoms had decreased AP diameter of the spinal canal. And that's Crystal on the right, and you can see she's showing the spinal canal. So down the center, she's taking the spine that you see on the left, and she's turning it, and she's looking down the spinal canal, and you can see that there's a tube that runs all the way up and down the spine, housing the nerves. If you want, you can interrupt if you have any questions. You can interrupt anytime if you want. So centrally, there's a spinal canal, and also at each level, sort of like a highway, there's a little exit for one nerve to come out. So these are all separate vertebral bones divided by discs. Down the center is a sort of the superhighway where all the nerves travel in the spinal cord, and at each vertebral body, each level, there's a little exit for one nerve. That exit, where the nerve exits, is called the foramen. The pen is in the foramen right there. That's the DL4 foramen. The spinal canal has different shapes at different parts of the spine. So here's a sagittal cut, here's an AP cut, and here are transverse sections at each level. Frame and magnum is huge. C1 is huge. Actually, you don't have to point because I'm putting here on the computer. C1 is huge. C2 is very big. And you see how large the spinal canal is, C1, C2? That's why usually fractures or disease processes at that level do not cause serious neurological compromise because the spinal canal is so big. And we see that all the time. Who did we see recently? Remember that? What was that? Remember? The pannus and the C1, C2 instability?
Oh, yeah.
So they have a large spinal canal there. So usually they don't develop problems quickly. So C4, C5, spinal canal is a little bit more trefoil in the mid-cervical areas. T1 is pretty round. T6 is very small. Interesting. And usually in the spinal canal, the spinal cord has very little room for extra CSF at that level. Then the spinal canal gets larger at L1, L3, L5 is very large, and S1. And then as you get down in the lower sacral segments, it kind of gets real small. There's no nerves there anyway, so you don't really need a spinal canal. And these people have been measured, and just a ballpark measure of the mid-sagittal diameter or the AP diameter in the cervical spine, it should be about 13 or 14. And the number we give for stenosis in the cervical spine, mid-sagittal diameter AP, do you know what the number is by any chance? It's 10.
10.
Yeah, 10. So it should be around 14, but you see here the range of all people is 11 to 18, 9 to 19, 10 to 18. It's almost double. Some people 11, some people 18. It's almost double. And in the lumbar spine, the mid-sagittal diameter should be like 17, 16, 15, 14, 17. And usually in the lumbar spine, spinal stenosis is usually less than 100 square millimeters, so 10 by 10 millimeters. So this is helpful because during the day we could see an MRI scan, we can measure it, and we say, well, it does have 10 by 10 millimeters. There's other things you can do too. So when patients come to you and you're suspicious of lumbar stenosis, you just ask a history. What questions can you think of you ask to see if it's lumbar stenosis?
Where specifically they're feeling pain?
Yeah,
so
take your finger and point exactly on your body where you feel your pain, because people won't do that for you. They just kind of describe it in abstract descriptions like my back hurts, my legs hurt, but they don't point to it. So take your finger, point to where it hurts, and point to where it travels. What other histories? Things?
How long they've had it?
Yeah, so timing, and then
what if they've had any types of treatments, and if they've helped.
Yeah, and also what kind of positions?
What makes it better? What makes it worse?
Yeah, so what provokes it, palliates it, quality region, severity, and timing. And usually neurogenic claudication, people say, like, what do they usually say? There's this one. Can you remember the last person we saw? I remember he said, when I stand at church, I can't stand. So church is one time where everyone has to stand for a certain period of time. And it's embarrassing to sit down because there's like a social stigma of just sitting when everyone else is standing. So that's sort of a test. And we're kind of a religious society in Hartford County. So they say I can't stand at church because standing decreases it makes the low back pain, neurogenic claudication worse. So they sit, and they recall that. I mean, they're not going to remember sitting at a Ravens game because it's okay to sit, but at church, they have a hard time. What other things can you recall?
Well, like your first slide, using the grocery cart. They have to walk with a cart. Yeah,
they bend forward to the grocery store because they have to walk a lot grocery shopping because it's a long walk at the grocery store. It's probably like a mile probably, and so they don't you don't think of walking. Because you're young, you don't think that the grocery store is a walk, but for an older person, that's a long walk. It's like 10 aisles, 12 aisles you have to do. So basically, you're doing a mile walk at the grocery store, and everybody has to eat. So that's at the grocery store when you see these people figure out they have a problem, and then at home they just don't walk. Any other times? Other? Go ahead if you have one. I gotta tell you some more.
Yeah, keep going.
Doing the dishes. People say when I do the dishes, you have to stand for 15, 20 minutes. You can't sit and do the dishes.
A lot of people sit and prep for their cooking.
But they can't. But
so
dishes you sort of have to stand.
Right.
Yeah. So this is just some histories. So you may say, well, when people come to me with low back pain, what things should I worry about? So any kind of nocturnal pain is always worrisome for an occult fracture, infection, tumor. Pain at rest, progressive neurological deficit, obviously the legs getting weaker or number. Or if you have any suspicion for cancer, the patient has a history of cancer, or if you have a suspicious for an infection. And so a high index of suspicion for like a serious problem, like an urgent surgical problem, is patients with cancer, because why is that?
Metastasis.
It could be a metastasis in the spinal canal, the vertebral body, or it could be a fracture. Patients that have severe osteoporosis, steroids, immunosuppressed people. Ankylosing spondylitis patients, why is that? Whenever an ankylosing spondylitis patient comes to you with pain, why are you concerned?
Fracture.
Yeah, fracture. So and it could be a chronic fracture, and it could be a fracture with a very small injury, like just a simple fall or something like that you don't think of. Patient with 10 out of 10 pain. Weight loss, IV drug abusers always are suspicious of an abscess, and patients with sepsis or urinary tract infection. So that's, I've seen many times in the hospital where patients have low back pain and they're admitted for urinary tract infection. So the first thing that comes to my mind is abscess. So just on exam, when you extend the spine, the pain gets worse because it buckles the ligamentum flavum. So this is just a case of an 81-year-old man with a long history of left, greater than right, lower extremity pain, low back pain. He has a history of prostate seeds at the age of 44, which is pretty young. High blood pressure. He's a retired carpenter. He's a large man, 6 feet tall, 220 pounds. He's neurologically intact. So what are so far the findings that you see on the sagittal cut?
Well, bulging discs at almost every level.
Well, 5-1's okay, yeah, but 4-5 bulging disc, 3-4 bulging disc, L2, L3 bulging disc, L1, L2 bulging disc. What else do you see? How about on the backside? What's this black stuff right here, like this circle?
Is that ligamentum flavum?
Yeah, that's the ligamentum flavum. You see how it connects the lamina to lamina?
Right.
So he's got on posteriorly, yeah, hypertrophy ligamentum flavum on the sagittal cuts, doesn't he? See that? So he's got basically stenosis. If you had to summarize this view at this point in time, what would you say?
That he has stenosis.
5, 4, 3, 2, 1.
L1, L2, L2, L3, L3, L4, L4, L5.
Yeah, so stenosis.
L1, L5.
Yeah, stenosis from L1, L5, and normal alignment. No spondylolisthesis. So nothing really new on these views. Very similar findings of bulging discs, and you can see the spinal canal is very small here. Okay, there. Very small there. Very small there. Okay, there. So these are the axial cuts. How's L5S1?
L5S1 looks fine.
Yeah, L405?
L405, put your little drawing in there, is more trefoil. There's not much CSF.
No CSF about the nerve roots, right? See, there's plenty of CSF around the nerve roots here, but no CSF here. What are these black things here? It's either one of two things. This black stuff that's compressing the spinal canal.
Is that the ligamentum flavum?
Yeah, it's the ligamentum flavum, or what else is here?
It could be the facet
Capsule. Yeah,
Yes.
facet capsule. So the facet, just like we saw yesterday, remember when we were doing the surgery, we were in the facet and we saw that the capsule was really thick and it had all that white stuff,
Right.
which looked like calcium pyrophosphate deposition disease. So the capsule can get really inflamed and enlarged too. So it could be both. Okay, so 4-5 stenotic, 3-4, similar findings, right?
similar, has some
2-3,
CSF. 2-3 is not as bad,
1-2,
but is tighter than 2-3.
and T12L1.
It looks normal.
Yeah. So what I usually do instead of just giving a number to people, like you should be 10 millimeters, you should be 12 millimeters, etc. People are different sizes. So, what I usually, as a rough measure, is I just look at T12, L1, and L5S1. They all should be very similar. So you can see they all should be similar to these two, and the other ones are not. So that's kind of my rule of thumb of if someone has stenosis, look at the other levels as a control. So the spine, just for recall, is a column of separate bones stacked on top of the other, and if you do a sagittal cut, there's a spinal canal, and there's a spinal canal is where the nerve roots run. The facets are right next to it, the pedicles. Now, when you do posterior approaches, you have to cut through a lot of muscles, and whenever you cut through the posterior muscles of the back, it's painful, and also it can cause weakness. So all of these, why do human beings especially have very strong extension musculature in their spine?
To walk erect.
Yeah, so we need these things. We need all these connections to walk erect, and if you cut through them, it causes disability. So the standard way in the past to treat spinal stenosis was a full laminectomy. So basically you cut from pedicle to pedicle and lift everything off, and that gives you a really wide decompression. So you cut from pedicle to pedicle and you remove the entire lamina and the entire posterior spinous process. And when you do it in this manner, it's a very wide decompression, and there's no question the nerve roots are going to be decompressed. The problem is what?
More instability.
Yeah, so the spine will start moving abnormally. So it's probably as a result of removing the interspinous ligaments. So posteriorly, these lamina are not connected anymore with the previous ligaments. And also I think, this is my personal opinion, the musculature is not attached to the spine anymore. So there's no attachment to the spine at these levels as well. And I think that's why laminoplasty works, because the muscles and the muscles scar down to the lamina again, and basically the anatomy is normal again. That's why laminoplasty works, I think. I mean, I may be wrong, but that's my opinion. So then another type of decompression is porthole technique. So porthole technique I learned from my former partner and mentor, Chuck Edwards, and his fellow was T.J. Kleeman, and he wrote this up as a porthole technique. So basically the area that gets stenotic is at the level of the facets. So where you get stenosis is not at the level of the pedicle. Like this level is always open in patients with stenosis. It's usually at the level of the facets. And I'll show you an example of that later. So if you just decompress at the level of the facets, you fully decompress the nerve roots in that manner, but you leave the posterior spinous processes intact, and you leave all the ligaments intact, and the muscles can scar down to this remnant of a lamina, so you don't get unstable afterwards. So, and this is usually done with an you open it normally, but then you just do this porthole. So we do portholes sometimes, right? I used to do that for years, but then, so here's a full laminectomy, here's a porthole decompression, and then mostly as a result of the improvement of the microscope, we're able to do these now through smaller incisions and through smaller holes, I think, personally. And this is a unilateral laminectomy bilateral decompression, which is basically the essence of our talk today. So you only decompress from one side, and that way all the musculature on this side stays intact. So all the strength of the muscles, they're not cut, they're not damaged in any way. Just one side's injured, basically, from the surgery. And you shave down the ipsilateral side, and then you sort of shave down the posterior spinous process and lamina on the other side, and then you can decompress both sides of the spinal canal from a unilateral approach. So this kind of shows an after and before of what it should like afterwards. So this actually patient may have had a fracture of the posterior spinous process. You see that? And that's one thing that may happen if you cut too much. Sometimes it's just not possible. And this, we'll go over some more studies, but this has been reviewed. This has been described in many articles. When I started doing this myself, just as a I was just decompressing one side, and I realized I went all the way to the other side of the spinal canal, and it just kept evolving, and I just started doing it myself. I thought I was inventing the technique, but then when I looked it up and I did some study, it had been described in Germany first. So this is just a standard technique of a full incision, open both sides, and do full laminectomy. As you can see, I can fully decompress it. So this is just an idea that between the two lamina is this yellow ligament, the ligament flavum, and this is a key. This is a key stabilizer to the spine, but it also hypertrophies and compresses the thecal sac. So you have the ligament flavum that goes from lamina to lamina. Also, you have the posterior spinous processes. Also, you have the interspinous ligament, which gives stability in the middle, and then there's also on the top, there's a thickness of the ligament, which gives it stability. So using the portal technique and using the unilateral laminectomy bilateral decompression, these two are kept intact. The ligament flavum, though, unfortunately, is removed. And also some of the capsule is removed from the facet, which gives some level of instability. So this is just showing you where the capsule is on the facet, and that it gives you some stability. But of course, there's also stability from the disc and also the ligaments along the disc space. So the surgery is done in a prone position on your belly. I just use a Jackson table. The C-arm X-ray machine in the operating room proves the level where we are. And this is the newest microscope, the Leica. We have the Leica OH4. This is the Leica 5, but the OH4, which is very, very good optics, but also extremely easy maneuverability. So you notice, you probably realize, because you use the old microscope, but how easy it is for me to focus, how easy it is for me to move. It's just so easy.
And they just upgraded the lights, the lamps on it.
So it's even better?
Right.
So the surgeon and the assistant can work at the same time. You can use, I use a tailor retractor because I think it's just simpler and easier, but you can also use tubes. So the essence of spinal stenosis, this is a spinal canal disc ligament, is to remove the posterior portion to give the nerve roots more room. And the ligamentum flavum is a fibrous structure that can hypertrophy and compress into thecal sac, and some people think it's like a benign hypertrophic process, sort of like a benign tumor. It grows abnormally, probably as a result of stress. So let's go over some normal anatomy. This is a normal spine. So normal vertebral bodies, normal discs, normal spinal canal. See, the spinal canal is very uniform all the way down? Mm-hmm. So L5, S1 is a nice round shape. There's plenty of CSF about the nerve roots. L4-5 gets a little bit smaller, but you can see plenty of room for the nerve roots, plenty of CSF around the nerve roots, and nice round shape. Same thing at L3, L4. I mean, this person has a frontal disc herniation, but essentially the frame is open, about the same size. Same thing at L2, L3, same thing as L1, L2, same thing at T12, L1, T11, T12, same. But then spinal canal starts to get a little smaller. So this is an optimal spinal canal, and most people are like that, but again, some people are born with developmentally small spinal canals, but this is really what it should look like. It should not be focally small on one level. So this is an 85-year-old male with low back pain, biosciatica with ambulation, and it resolves when he sits. And the x-ray is pretty normal, right? AP lateral views, no malalignments. What do you see on the MRI?
Let's see, 5, 4, 3, 2. Disc bulge L1, L2.
A little bit. 2, 3.
Bit, and a little 2, 3. 3, 4. Actually, 2, 3, and 3, 4 of hypertrophy from the ligament flavum. Yeah. So posteriorly.
Yeah, it looks like it's more of a posterior process, right? See how
Right.
this is really big, this is really big, this is really big, and the disc bulges are not that big.
Right.
So this seems like more like a posterior process. 4, 5, 3, 4, 2, 3. So 5, 1.
That looks good.
4, 5.
Very tight.
Very tight. So then if you go just a little bit higher to the pedicle of L4, looks
It's
fine.
open. Right.
Right. So you see the area where it gets stenotic is really at the facet
The level
usually.
of the facet.
Yeah. And then 3, 4.
It's very tight.
Yeah, severe stenosis. At the level of the pedicle of L3,
Looks okay.
yeah, it's not bad. 2, 3.
Not as severe as the others, but still
Stenotic. Yeah. And the level of the pedicle of L2.
Looks okay.
Yeah. So this just shows you that at the level of the pedicle, you don't need to decompress because it's open. But then at the level of the facet, you need to decompress. So when I do these decompressions, I basically, in my mind, I'm thinking I have to go from the top of the facet to the bottom of the facet. And in the posterior approach, you see the facet where it is. So that's where, I don't know if you're wondering when I do this, but that's how I drill my initial hole. You know, I make an initial cut, like a circle where I'm going to go. That's what I do. I go top facet, bottom facet, and then that totally corresponds to the ligamentum flavum, because if I keep going down that hole, I get to the top of the ligament flavum and the bottom of the ligament flavum. And if you
just always extend until you get to the end.
Until I get to the top of the, yeah. So that's kind of like the purpose, and the purpose is to open the spinal canal. Okay, so this is the same case as before, and you can see, instead of doing portholes, what I usually do commonly is just a trough all the way up and down, and then decompress both sides of the spinal canal so unilateral laminectomy on one side, and I decompress both sides of the spinal canal from a unilateral laminectomy. So this elongated trough has risks, benefits. The benefit is faster, and also more light gets into the spinal canal. So I feel I can fully decompress and be confident that the whole spinal canal is open if I do a connecting trough all the way up and down the spinal canal. Unlike the porthole, where not as much light, and I'm never 100% sure because I can't just visually see that the spinal canal is fully open. But you can do a porthole technique and open the spinal canal. It's a little bit more tedious because every single time you have to find the spinal canal when you do the decompression. But the risks, so you better direct visualization of full decompression of the spinal canal from a trough technique, elongated trough for multiple levels. But the negative is you get a pars fracture because maybe you remove too much the pars area, and it weakens the spine some. So if you're concerned about stability or weakness, it's probably best not to do the trough, but it's just, usually I do the trough, but I'm not sure what the answer is, like what's better or worse. So just a couple articles, recent articles about unilateral laminectomy bilateral decompression. This one's from Korea last year, European Spine Journal, where they reviewed 144 single-level decompressions, and they categorized the decompressions into 3 different types. Patients that had a round spinal canal, where the mid-sagittal diameter was bigger than the transverse diameter. Patients oval, where mid-sagittal diameter was smaller than the transverse diameter. And trefoil spinal canal, where it looks like a triangle. So they had 3 different groups, and they found that the trefoil canals did not do as well as the round and oval. And their thought was the trefoil spinal canal was just more difficult to decompress because of the angle of the decompression. I mean, personally, I don't feel that way. I think round and oval spinal canals just not as stenotic.
Right.
Okay. This is another article, Journal of Neurosurgery, Spine 2014, from Dr. Mopes, who's in Australia, and 79 patients, and he prospectively, this is a good study, he prospectively evaluated these people on a one-to-one basis. He did unilateral laminectomy bilateral decompression versus just a standard open laminectomy, which is, I mean, basically the best thing you can do to study this. And he evaluated them post-op for Oswestry disability, which is just a disability index, patient satisfaction index. And he found that the unilateral laminectomy bilateral decompressions had a shorter hospital stay, 55 hours versus 100 hours. So
almost half.
Yeah, so 2 days versus 4 days. And shorter time to mobilize, 15 hours next morning versus 33 hours, which is like post-op day 2. So basically, people mobilize on post-op day 1, ULBD, post-op day 2, full laminectomy. And if you look at the people who did not require any opiates at all, half of the ULBD patients did not need opium at all, versus just 15% for the laminectomy. So they just don't hurt as much. So this is just basically a study of initial results. And do you agree with this? I mean, you know.
Well, it makes sense. You started talking about just cutting through the musculature is painful.
Yeah. So you cut half halfway through the musculature. And then just clinically, you see these people fly. I mean, they do really well. They walk right away. They don't complain much of pain. So this is another study from 2006 from neurosurgery, and it's long-term results of microsurgical treatment, ULBD, done in Germany, which is, I think, is where the first articles were on ULBD. And it's 133 patients. Follow-up was up to 10 years, so long-term follow-up, and the mean was 5.6 years. And the reoperation rate was around 11%. 2 patients became unstable, 2 out of 133. 7 patients did get recurrent stenosis, and 85% had excellent to fair long-term results. So this basically are very good results, and these are small surgeries for patients. So I just put this together. These are the pitfalls or complications for ULBD. First of all, restenosis. You're not doing a full wide laminectomy, so it can happen again. So the bones can get bigger, you get hypertrophy, the capsule can get bigger, hypertrophy, and compress the thecal sac again. Usually I found it's on the opposite side of decompression. So if you do a left side unilateral approach, the right side becomes symptomatic. But in my mind, that's not a big deal. I'll just do another ULBD, which is a very small surgery for these patients. And usually they still do fine. I don't even think you have to go to a fusion after that. So these are very small surgeries that are very helpful for people with few risks. Other possible risks are just dural tear. I think we don't get that many.
With both, though.
You can get it with both. I think dural tear is a little bit more because it's just technically more demanding. It's a lot harder than the full laminectomy. But I think with experience they're equal. So just because it's technically demanding, there's a higher risk for nerve injury. Instability is always a risk, but I think less than a full laminectomy. You can get persistent pain from facet pain afterwards, but that's the same thing in laminectomy too. You can get a pars fracture, but again, you can get a pars fracture from a laminectomy. Probably higher incidence of pars fracture from a full laminectomy because you're decompressing both sides open. While with the ULBD, you can probably just get a pars fracture from just one side. And the other thing is inadequate decompression. I mean, you're doing through small holes, small incisions, and there's always a chance that you don't open it up enough. But I've found that it's been very rare. So we won't get into that. So any questions up to this point?
Nope.
Okay, so this is another case, 77-year-old woman with left leg pain, low back pain, and she had a previous decompression, ULBD 2 years ago. So I just showing you some failures. Just what can happen is she had the ULBD, she did great, but then she, at the same level, she herniated a disc. This is above, and this is the level of disc herniation. And I don't know if you can tell, but you can see that she's from the scar, she's been decompressed, but then she had this huge reherniation of the disc. So this technique, you can still have problems at that level. Do you think this is a result of the surgery, or you think it's just a result of the natural history of this level, which just happens to be a diseased level?
I mean, it was 2 years prior to the surgery, correct?
Yeah.
So it's probably just natural progression.
Yeah, I think some people just have a bad disc. They just have, like you have a bad knee, you have a bad hip, you just have a bad level, you have a bad disc and facet, which is just going to keep deteriorating. But this person, I just did a discectomy. She did great. The other thing to consider is that some people just have really, really short pedicles, like this patient, and this patient may need a laminectomy. I'm not sure, but some people have unusual anatomy. So each case you have to think about it a little bit. So here's another case: 58-year-old man, left great and right low extremity pain. He had a left L5S1 discectomy years ago. So what are your findings on the sagittal cuts?
Here's another L5S1.
Disc herniation, L5S1, some ritualocesis, right? What else?
Some posterior hypertrophy, ligamentum flavum.
Yeah.
4-5.
4-5 looks like ligamentum flavum is slightly tight, doesn't it?
3-4. 4 looks okay.
Yeah, not too bad. 2-3.
Looks okay.
Normal, right? So axial cuts, L5S1.
Where are you pointing? Okay, L5S1 is actually that doesn't look that bad.
Not too bad. 4-5.
4-5 does look tighter.
Stenotic, no CSF about the nerve roots, very small spinal canal. And see at the level of the pedicles, it's fine there. So it should all look like this. It's 4-5. So flexion extension views, no real
decreased disc height L5S1.
Yeah, decreased disc height, but no instability. So this patient, I just did a revision decompression at these 3 levels. I didn't show you L304, but L304 was stenotic as well. And I just did unilateral revision left L5S1 lamina femoral decompression because I wanted to be sure that nerve root was free because he had sciatica. And I opened up both sides of the spine from a unilateral approach. Okay, next case. This is another failure case. 84-year-old with left sciatica. What do you find? X-rays.
I'm sorry, I get distracted by your drawings. Decreased disc height, gosh, at every level.
Every level.
Anterior osteophytes.
Anterior osteophytes. AP view?
AP, I don't know, 35-degree
scoliosis. So pretty good size scoliosis. What do you think of the discs?
Is this sagittal?
This is a coronal section through the spine.
You're on the right side.
Vacuum sign.
Vacuum sign at
subluxation here. And big osteophyte.
Look at the osteophyte. That's
massive, isn't it?
Really interesting.
Yeah. So this is the axial cuts, and you see this trefoil spinal canal, a foraminal disc herniation. L5S1, L405 is trefoil, L304 is trefoil. Remember she had left-sided leg pain. So this patient had scoliosis, and I mean, one option would be basically L1 to L5 laminectomy fusion. Fix this curve, maybe even straighten it out, fully decompress. I mean, for 84 years,
84.
she probably won't survive it. And if she survives it, things aren't going to be good. I mean,
and it looks like her spine's trying to fuse itself.
It is.
Anyway.
At 2-3 though, but not 3-4-4-5, where she has a problem. So, I mean, so what I just did is, because she had trefoil spinal canal at each level, I just did a decompression only, and tried to open the foramen. Well, it didn't help. I mean, afterwards she had some improvement, but afterwards she said her leg pain was even worse. They gave her steroids, gave her some pain meds, they gave her time, but it just was not getting better, and she was just not happy at all. Not a good existence. So I repeated the MRI. And what do you think of the spinal canal at 4-5? Centrally
Looks good.
But what's the problem?
Still the foraminal stenosis.
Yeah, so still the frame is still tight there. So centrally her spinal canal had been opened very nicely, but just this herniated disc in the foramen was her main problem. You can see the foramen here on the sagittal cut. So just in my experience, it's hard to decompress the foramen. I mean, it takes a lot of time, and you have to be careful because you don't want to get a pars fracture. So I wasn't, preoperatively, I didn't realize that the vast majority of her symptoms were coming just from this foramen. So it wasn't a real focus of mine. So I just took her back for a revision foraminotomy and a big discectomy there, but I kept the pars intact, and this patient did great. But this is just pitfalls that you have to. It's hard to decompress the foramen sometimes from these limited approaches. So it's just a consideration. That's where you're going next week. So,
That's where I'm going?
That's Cape Hatteras, yeah.
I am?
No, this was
Okay.
So any questions about unilateral laminectomy bilateral decompression?
No, I thought that was really helpful.
Yeah. Yeah, and I think the future is in these limited procedures for people, and we could do them as outpatients. We could do them at the surgery center. So, personally, I do a lot more of these decompressions and fusions, and I think that people just do better.
Right.
So, I think it's a good procedure.
And even when you present like options to patients to try the smaller one versus, just this procedure versus a larger fusion, most of them want to start with this, even if they realize in the future they might need more.
Yeah, most people, well, first of all, most people are old. So they're like, I don't want something big. I'm an old man. I don't want to take a risk. So I'd much rather do the smaller one. I think it makes sense. As long as there's minimal deformity. Okay. All right. Thanks for coming.